Everyone, really welcome to another session of our updates in urologic oncology. Dr. Matulewicz is a urologic oncologist, formerly at Northwestern as a resident, and then he did his SUO fellowship at Memorial, and he's now a urologic oncologist on faculty there at Memorial. His research and clinical efforts are around urologic oncology, but specifically he's focused on improving disparities for men and women with urologic cancers. Tonight he's going to talk about implementing smoking cessations in a urologic oncology practice. We're really glad to have you again.
Really great to be back. So thanks very much, Dr. Ross. I am going to talk today about one of my passions here is implementing smoking cessation into the urologic oncology practice. This is a pretty good summary of the last 2 or 3 years of work that I've done since leaving Northwestern, and certainly at the end of my fellowship and work I did a little bit while I was at NYU before coming back to Memorial. So as discussed or as listed, I have no conflicts of interest here. So just to kick things off here, we know that smoking either causes or exacerbates the severity of several urologic cancers, most notably kidney and bladder cancer. And the population attributable risk, that is what percentage of bladder cancer cases are caused directly from smoking, is about 50%. And this is up there with head and neck cancer and lung cancer. And compared to never smokers, those who are current or former smokers are at anywhere between a 2 and 5 times greater risk of developing kidney and bladder cancer than those never smokers. And similarly, patients who are treated for prostate cancer that smoke have an increased risk of recurrence. So this really touches all of the major cancers that urologists treat. And of note, the effect of smoking on urologic cancers, the incidence and the continued morbidity associated with this is actually getting worse, not better. And this is probably due to changes in the composition of cigarettes over time, despite the lower tar content and lower overall prevalence of smoking. So this is actually getting worse. And as urologists and oncologists, we care for about 3 of the top 10 cancers in the world, and all of these are directly or caused or exacerbated by smoking. And relative to some of the other more common smoking-related diseases, such as lung cancer, head and neck cancer, cardiovascular disease, this is woefully underappreciated and understudied relative to those. And although this talk is focused on urologic oncology, the burden of tobacco-related disease does not stop at the malignancies we manage. The several benign urologic conditions are also caused by or exacerbated by tobacco use. Most of these are through similar mechanisms. Small vessel disease does increase the risk of erectile dysfunction, certainly infertility, kidney stones, and lower urinary tract symptoms. So, how does smoking cause cancers, specifically urologic cancers? Well, the curing and burning of tobacco leads to the generation of several carcinogens, including nitrosamines, aromatic amines, and then polycyclic aromatic hydrocarbons, all of which are known potent carcinogens, and they're specifically linked to bladder cancers. So these chemicals are then filtered by the kidneys into the urine, and then they're rapidly absorbed by the urothelial and renal cortical cells, which lead to DNA damage. And some people are actually at a higher risk of carcinogenesis when they are seeing these carcinogens, and this is based on some germline genetic susceptibilities, and this is work that actually Josh Meeks has done some nice work in. So this leads to DNA damage, and as I said, some of these genetic susceptibilities, and in total there are about 100 chemicals that are produced during the curing of tobacco and burning, a lot of which are actually known to affect KRAS and P53. So this is certainly a generation of DNA damage. So the good news is smoking is becoming less prevalent. And in 2020, the Surgeon General released the first report on smoking cessation in over 20 years. And this does show the considerable progress made at the population level. And as you can see here on the left, in the 1960s, upwards of 50% of all men were smoking, and this is very nicely declined. Unfortunately, these trends do not necessarily extend to survivors of GU cancers. And this was a study that we published using the National Health Interview Survey. We generated a population level estimate of roughly 4 million patients with a history of urologic cancers, and we found that between 15 and 20% of adults with either a kidney or bladder cancer continue to smoke. And this translates to an overall burden of nearly 250,000 people per year that we see in our clinics that continue to smoke with these cancers. And from other studies, we know that patients who are diagnosed with bladder cancer more than others are some of the most stubborn and persistent smokers after their diagnosis. And this is really where the significance of my work lies, is in this population. So just as some background and to frame some of the work, certainly the exploratory work that I've done, I think it's important to understand what is the current evidence-based practices related to smoking. Certainly the first step in all of this is really assessing smoking status, and this is something I'll harp on, the screening process. And then from there, it's really a combination therapy where there's a mixture of counseling and behavioral therapy delivered to help support the smokers, and then pharmacotherapy. And this combination of therapy has really been proven time and time again in systematic reviews and meta-analyses to be the most effective. And there's a lot of different mnemonics that can be used to remember these the components of this pathway, including AARP or the 5 A's, and I'll get into that in a little bit. Why is this important? If someone already has cancer, why is it important to address these issues? Well, at least in bladder cancer, and there is developing evidence in kidney cancer as well, smoking cessation after diagnosis does impact outcomes. So not only do we see worse radical cystectomy and TURBT outcomes perioperatively, there's higher anesthetic risks for those that continue to smoke, and there's actually a greater risk of both chemotherapy and radiation adverse effects and toxicities, and actually less benefit in patients who continue to smoke when given neoadjuvant chemotherapy. So although the damage has already been done to some extent, helping patients quit smoking even after diagnosis does lead to discernible outcome benefits. So why aren't patients quitting? And this is really where I started all of this. So when I began this work about 2-3 years ago, there was nearly nothing in the literature assessing any sort of determinants of smoking cessation practice in urology, not at the system level, the clinician level, or the patient level. And all of these different components certainly contribute to a patient quitting smoking. So in order to fix something, you really need to understand, why it's broken and how to address some of these gaps and what the determinants of these gaps in care are. So we started with a few hypotheses, and the first was that patients are generally unaware about the connection between GU malignancies and smoking, and there hasn't really been much that looked at this previously, but this was sort of an anecdotal observation based on just taking care of patients. The second was that education and certainly physician advice, including the urologist, or especially the urologist, is impactful and important to deliver to the patients. But unfortunately, urologists weren't necessarily doing their part, and I was certainly guilty of this when I started all of this work. And really what this all leads to is that patients were not ending up getting evidence-based treatment, and this all kind of contributes. So to begin addressing this, I think the first part of this is the most striking, and this was a study that we did using the Population Assessment of Tobacco and Health, which is a longitudinal, nationally representative survey study, and that what we found was among the weighted sample of about 44 million U.S. adult smokers, people were markedly less aware of the connection between smoking and bladder cancer than any of the other very prevalent smoking-related diseases like lung cancer, mouth cancer, and heart disease. When we asked the same question about whether patients were aware of the link between smoking and bladder cancer, even among those patients who had a history of GU cancer, that's that second column in the middle there, this was still under about 60%. And then in this lighter column here to the right, in the red box, this was actually among patients who had a known diagnosis of bladder cancer. So not even 100% of these patients were aware of the potential risk, and these are patients who were actively smoking, the potential link between their continued smoking and their diagnosis. So this certainly established that gap. And how about urologists? So this was work done by Dr. Berlin, who's a persistent collaborator of mine at UNC, and Dr. Hollowell, who's certainly one of the inspirations for a lot of this work down the line. This was a study that they did back in 2010 of American urologists, about 600. And at this point, about less than half ever discussed smoking or smoking cessation with their patients. And about 40% actually believe that smoking cessation probably wouldn't alter the course or outcome of their disease. This data, although it's a little bit dated at this point, 10 years, and I'll show you some updated information soon, really demonstrates that urologists were not necessarily doing their part, and there was a big gap in care here. So why is this important, and why is this falling on urologists? Why should urologists bother using valuable clinical time with something that should be quote unquote outside our purview or dealt with by primary care doctors? And really the reason is that our advice carries weight. The surgeon, your cancer doctor, our words have a lot of gravitas, and this is something that we studied and we proved in a study I did with the UCLA group that assessed or rather queried about 400 patients from the California Cancer Registry about their sources of information, their perceptions, and then their quit behaviors around the time of their bladder cancer diagnosis. What we did was we compared these patients to a population matched controls from the California tobacco system, and what we found was that urologists are really far and away the most trusted and utilized sources of information regarding the cause of smoking-related diseases, particularly bladder cancer. And another important finding of this was that compared to population level or population controls, smokers that had a diagnosis of bladder cancer were 5 times more likely to quit than those in the general population. And this really is the crux of some of what I'm going to talk about in a little bit, and that's the teachable moment of a bladder cancer or urologic cancer diagnosis. Sorry, I'm trying to click through. So what else? The other thing we found in the study was that education and awareness does lead to bladder behavior change, and this again is that crux of that teachable moment. And these responses here indicated that urologists' advice to quit and the information given about the importance of smoking cessation at the time of diagnosis was the most important driver of quit attempts, and this really kind of drives home the importance of education to this process. So doing a deeper dive into patients' perceptions, behaviors, attitudes towards tobacco use, because we really want to meet patients where they are and fill in the gaps based on what our patients perceive and what their self-efficacy is. We went back to that PATH study and performed another cross-sectional national analysis of about 500,000 smokers with a history of urologic cancers, and we found profound differences in how patients were told to quit by their doctor based on their disease state, and differences in their attempts to quit or plans to quit. So this kind of really supports the notion that a one-size-fit-all approach is probably not best for all of the patients we see. We also found considerable differences in readiness to quit among the different cancer types, which again, that one-size-fits-all may not be the best way of doing this. So although the underlying reasons and beliefs behind these behaviors and perceptions are not necessarily clear, this is supporting some of the qualitative work that I'm doing in this space as well. But notably here, what I do want to call attention to is that most patients are falling in those leftward and middle categories, being very ready, or at least somewhat ready to quit. And this is an important finding given how influential self-efficacy is in behavior change. So if our advice is important and education is critical and most patients do want to quit, how are we doing as clinicians? And really the first step in tobacco treatment, as I've said, is screening. So without screening for tobacco use, you're never going to identify someone as a smoker or a tobacco user. So this study that we recently published used another national data set to provide population level estimates of outpatient clinical practices for urologists. This looked at an estimated 64 million outpatient urology visits over a 3-year period. And what we found was that urologists actually are fairly often screening for tobacco use. But that's really where where those use of evidence-based practices falls or ends. We also found considerable variation in the aggregate physician level practice, as you can see here. These are unique physicians and the offices sorted by how often patients are being screened for tobacco use at all of their clinic visits over the course of these 3 years. And really the most important finding of this is that, we may be screening, this may be something that is actually getting picked up just as part of our intake, but there's not necessarily any differences that we're seeing based on the patient's chief complaint or differential diagnosis. So this is not necessarily a targeted process. This is sort of a more passive process. And that's really echoed by the downstream treatment for smokers in these practices, where only about 7% were counseled and only about 3% had any nicotine replacement therapy or prescription medication ordered as part of these visits. So another aspect of the study that was really important was to determine how prevalent tobacco use and tobacco-related disease was in our clinics. And we looked at visits that were primarily for urologic cancers, infertility, hematuria, and erectile dysfunction, all things that I think you could pretty safely consider as either tobacco-related or adjacent among active smokers. And we found that each year we're seeing more than about 1 million active smokers in our clinic, and nearly 500,000 of those have a directly tobacco-related diagnosis. So really, this provides ample opportunity for us to intervene, and not necessarily intervene just once, but also provide support as we see our patients over and over again. So taking a bigger step back to the system level now, In an effort not to reinvent the wheel, we wanted to assess some of the prior attempts at implementing smoking cessation best practices into urologic care. So to do this, we performed a systematic review of all interventions or all studies that aim to promote smoking cessation in urology. And in general, we found very few high-quality studies, and about a total of less than 600 patients have ever been included in any prospectively studied intervention in the reported literature. Most of the studies that we did find were retrospective, had a high risk of bias due to the nature of those studies, and they also lacked standardized measures for both the assessment of smoking, quit definitions, and also for the treatment that was given. Really highlighting those four prospective interventions, and again, this is about less than 600 patients ever included and reported. Importantly, most of these studies also lack the use of dual treatment. That's the behavioral intervention and pharmacotherapy. And actually the largest one we included, was a study performed at MD Anderson, which was at the entire center level, so not necessarily specific to urology patients. And many of these actually included other things like lifestyle changes, which has certainly been shown to be helpful in patients with polysubstance abuse, but it makes it a little bit more difficult to tease out some of the effects of those. So how to approach improvement? I've kind of spent a lot of time now pointing out deficiencies and gaps in care, but how do we go about actually fixing this problem? So although the ideal interventions would kind of take place along the entire continuum of medical care, this whole spectrum of prevention medicine, primary to tertiary, when it comes to preventative medicine, just based on when we're seeing patients in our clinics and in the OR and stuff like that, our focus unfortunately has to land predominantly in the secondary and tertiary prevention stages as urologists and oncologists. So keeping this in mind when we're considering interventions and improvement, it's important to understand where we may be most effective and where we should best intervene given the lack of infinite resources. So we started to take a look at this from other angles as well, and there are ways of approaching this issue beyond our clinics. And historic smoking intensity or changes in smoking status over the course of a therapeutic study were never really collected, and they may have a significant moderation effect on outcomes, including survival outcomes in long longitudinal studies. And this was a systematic review that we undertook to figure out just how often tobacco use was being collected and reported in these landmark GU studies. So by not collecting this information, there's really no way of assessing this potential interaction that tobacco use has on these outcomes. And although this is recommended by several different guideline committees and large-scale societies, tobacco use is recommended to be collected at both trial registration, throughout treatment, and also part of long-term follow-up. As we showed in this study, in a number, about 350 phase 2, 3, and 4 studies in GU oncology, roughly 92% didn't report or collect any data on the patient's tobacco use. Among the few studies that did collect or report this data, it was done qualitatively, meaning simply as either never, former, or current. There was no details about intensity, duration, or any of these other fairly important metrics when you're looking at the effect that tobacco use has on some of these outcomes. And pretty much none of these studies used any sort of standardized measure or validated instrument to collect this information. Importantly, in 2 of the 3 studies, there were subgroup differences among patients with different smoking statuses, kind of supporting that signal that there may be some moderation effect here. So similarly, given the known gap in knowledge, even among urologists and certainly among patients, another avenue to approach this is through dissemination and awareness through clinical treatment guidelines. So this was a study we recently published in Journal of Urology that compared just how often tobacco screening and cessation recommendations are made in bladder cancer compared to lung cancer guidelines. And again, what we're seeing here is that we're lagging behind some of those other similarly prevalent tobacco-related cancers in that very few of our guidelines even mention tobacco use screening at the time of treatment or consultation, and less than half recommend smoking cessation as an integral part of treatment, which is certainly something that I believe very strongly in, that should be a component of our treatment for these cancers. So what do urologists think in 2021? This is something that I showed some data from Dr. Bierland and Hollowell before, and I'm on the AUA data committee, and this was data that was actually released last night. So although not publicly available at this point, what we can say is that compared to 2010, there hasn't really been much of a change in the interim. Most urologists are not providing or arranging any help for smoking cessation for their patients. But we did begin to try to understand what the ultimate or optimal, rather, approach to this may be from the urologist's perspective. And this is something that I'm certainly going to integrate into some of the later work that I do. But it does seem like most urologists want to kind of offload some of this treatment, but they are very comfortable in beginning this process by giving a strong recommendation to quit and then arranging for treatment outside. And this is something that is aligned with a lot of what is recommended from tobacco experts. However, we do need some additional qualitative assessment about some of these perceptions among urologists and some of the underlying reasons. So we talked about the teachable moment, and really a lot of this work, the crux of it is leveraging that teachable moment. We have patients who are having these health events, these bladder cancer diagnoses, other benign diagnoses, and really the heuristic model here on the right, what you can see is that the goal of the teachable moment and the behavioral psychology behind all of this is that these events can then be used to motivate individuals to kind of adopt risk-reducing health behaviors and really leveraging this somewhat negative event for a positive behavior change. So, where and when can this be done? Obviously, bladder cancer is a fairly complex treatment algorithm, and what we looked at here were some potential, we call them targeted intervention points or sort of discrete teachable moments in the bladder cancer care continuum. And I think that if you want to do this locally, it's sort of very important to understand, what the current local institutional practices are and to identify resources at each of these levels. Because what I can say with confidence is that there's no one specific point in the treatment pathway or treatment algorithm that we know at this moment, at least, is the best point for intervening. But if you do want to begin intervening, it's important to understand what your resources are and where this can kind of best happen. Something we're looking at MSK, and I'll show some data in a minute, is using the post-cystectomy admission as this kind of teachable moment, given that patients are generally a captive audience, given the several-day hospital stay afterwards. The lack of tobacco use allowed in the hospitals kind of helps promote this, abstinence. And then this is the time point where people can really be started on medications in a closely observed setting. So to support this, we looked at another national data set. This was through the Premier database, looking at the national level of inpatient initiation of smoking cessation pharmacotherapy in patients admitted after their radical cystectomy. So importantly, not only is this, there are some kind of theoretical benefits to doing this specifically for cystectomy patients, but this is a guideline recommended and actually evidence-based strategy that patients who are admitted, certainly for tobacco-related admissions, to start pharmacotherapy and then arrange follow-up in the space is something that has been proven in several randomized clinical trials and meta-analyses. And this is actually something that is promoted by the Joint Commission as well as a quality measure. So again, we use the Premier Healthcare data set. And this is an all-payer population level estimate of U.S. admissions. We looked at cystectomy patients who are current smokers, and our primary outcome was how often smoking cessation pharmacotherapy, that is either nicotine replacement therapy or prescription medications, were given to these patients. So we looked at this among about 16,000 admissions and smokers following cystectomy over the course of 8 years. And what we found was that this was, as expected, not very well utilized. Only about 30% of smokers received any sort of smoking cessation pharmacotherapy. And a significant percentage of this was actually continued medications that patients were on ahead of time. Most often, these were nicotine replacement therapies, kind of echoing again how often and how infrequent, I should say, and how uncomfortable urologists are with prescription pharmacotherapies for this purpose. We also very concerningly found that older patients and Black patients were less likely to receive smoking cessation pharmacotherapy here, calling into question a lot of the underlying disparities and biases potentially driving some of these practices. We found that those with more comorbidities and smoking-related diagnoses were actually more likely to receive smoking cessation pharmacotherapy, which does, again, support the notion that these were targeted specific behaviors rather than passive behaviors. And we found no significant association, as you may expect, with length of stay, readmission, or 90-day mortality, simply because our exposure was simply just writing the medication rather than the actual act of quitting. Again, we found significant variation in delivery across hospitals. These were hospitals in aggregate for all of the radical cystectomies that they performed over the course of these periods. And as you can see, several hospitals, among dozens, if not more, of radical cystectomy, roughly 0% of their smokers admitted after cystectomy received any sort of smoking cessation pharmacotherapy. And at the hospital level, we didn't actually see that cystectomy volume was associated with the delivery of SCP in this situation, which says that even high volume centers are not necessarily doing this. So again, kind of circling back to how to approach improvement locally. So this is where kind of my additional training after graduating residency is really coming into play. And this is something that a few urologists have really adopted in a theory-based fashion, but I was very fortunate to be mentored by Dan Makarov at NYU, who is one of the kind of early adopters of implementation science in urology. And really what implementation science is, it's the scientific study of methods and strategies that facilitate the uptake of evidence-based practices and research into regular use. So as you can see here on the right side, this little cartoon here, there's usually a gigantic gap between what we know is effective or efficacious based on randomized trials and really high quality data, and what we actually do in real world practice. So this approach, implementation science, is kind of this multidisciplinary approach to bridging that gap between what we would consider gold standard practices and what we're actually doing. So this is kind of the general approach to where I'm at right now, and where I'm going to start to try to improve some of these things that I've just shown are practice gaps. So the first effort into this was a study that I completed with the UCLA group, who were nice enough to involve me in this. And this is a prospective hybrid type 1 effectiveness implementation study that we did over the course of 30 months. And hybrid type 1 study is one of these implementation science studies that focuses primarily on the effectiveness of an intervention, but also studies secondarily the actual implementation of that intervention. So what we did in this situation was that at all new patient, or rather all outpatient urologic consultations over the course of this time period, at one point we implemented this multi-level strategy, which included both an EMR-based clinical decision support tool, and then also provider education given to the NPs, the MDs, and also the residents. So not only did we see whether this strategy proved effective, but we also looked at, through qualitative interviews and surveys, about how the people that we actually implemented this on felt about all of this, in a sense, or rather in an effort to improve this in the long term. So anyone that's used CPRS can kind of see, or rather recognize, these little prompts. And this is something that was built upon the usual tobacco query. But as you can see, as I cycle through here, what this tool ended up providing was really detailed script for counseling the patients and giving this directed brief intervention to say, this is how you're supposed to quit. And then it actually provided support to the person right at the point of care to not only place a referral to the smoking cessation program, link the patient with telephone resources, but it also helped prescribe these medications that most urologists are not necessarily familiar with. And although primarily our primary outcome here was to increase the use of screening and then hopefully have that trickle down to improved evidence-based treatments, what we absolutely found here was that using this prompt and using this method certainly increased the amount of patients who were screened, and then this really led to dramatic increases in downstream use of evidence-based treatments. So as you can see over the course of the study, this several 6-month lead-in period, about only 18% of patients were screened for tobacco use. And then after implementation, this went up into roughly the 60s. And this was something that over the course of the study was sustainable and maintained, given that the prompt remained in place. Unfortunately, we found significant variation at the provider level in screening. And this is something that obviously to get up to those higher numbers, the beyond 60% into the 80s and 100%, this is where that specialized sort of specific directed intervention or secondary intervention may need to take place. As I mentioned, some of these secondary outcomes, we assessed the profile of patients in the VA system, what their tobacco use histories, and as expected, patients who were current smokers had really long and intense smoking histories, which really strengthens the fact that among these patients, about 40% did want to quit. So this was a highly intense and long-term smoking population, but a lot of these patients did want to quit. Interestingly, they wanted to quit by a variety of methods. About 50% wanted to try cold turkey, and the other 50% wanted some formal help. And those actually with tobacco-related GU conditions were the ones more likely to seek more formal help. And then long-term, when looking at our actual service outcomes here, that among all of these patients that were smokers, about 40% made a quit attempt at 3 months, and then by 6 months, roughly 50% of these patients made an attempt to quit. And this is really a dramatic finding because in the regular population, especially in a smoking, really smoking heavy population, you're talking about only between 10 and 20% making any attempt to quit over the course of this time period. Interestingly, and obviously as a balancing outcome, we always want to look at what the opposite effect of some of our interventions were. And again, anyone who's used CPRS that doesn't like these prompts, what you can see here is that the amount of never smokers dramatically increased after the prompt was put in place, simply because this was a way of circumventing a lot of those subsequent things. So although this was quite effective in some of the things, life always finds a way, and people were able to circumvent this by simply just clicking the patient never smoked. So this was a dramatic increase in the amount of never smokers seen afterwards. So certainly still other ways to get around this. So where am I at currently, and what am I working on to kind of address some of these things that I've spoken about? So one of the things we're doing is a collaborative effort with some of the epidemiology folks and other tobacco experts at Memorial. This is Dr. Helena Furberg's DETER study. This is an ACS study looking at biochemical assessment of all patients with non-muscle invasive bladder cancer and looking at the actual differences in the biomarkers of exposure and their risk of recurrence over time. This was something that was fortunately just accepted yesterday, the Journal of Urology, so this will be coming out soon. And in this very high-risk recurrent population that we have here at Memorial, we did not show that the urinary carcinogen levels at the time of diagnosis or at the time of consultation was associated with recurrence, which is somewhat contradictory to some prior studies, but it does corroborate another recent study I did within the CISView registry, which looked at a similar population and the effect of smoking status on recurrence patterns in these patients. The other thing that I thought was very important from this study is that because we were using biochemical confirmation in patients' urines, we were actually able to compare what they reported to us and what was actually happening in their urine as far as their continued smoking or their continued exposure to either secondhand smoke or other tobacco products. And what we found was that there was actually a fair amount of discordance between what patients were telling us and what was actually found in their urine. So this is certainly an important concept. The other thing that I've been involved in is the National Cancer Institute's 3CI program, and this is the Cancer Center Cessation Initiative, and this is a national program at most of the largest cancer centers in the country, including Northwestern. And this is a really large-scale effort to deliver evidence-based smoking cessation treatment to all patients with cancer at these centers. And I've been involved in the implementation science working group, looking at both the reach and effectiveness of several years of funding in these centers, and some of the other reasons and kind of barriers and determinants of getting patients smoking cessation treatment. So a lot of work to be done there. Similarly, taking it down a step to the local level, and this is something that I'm using for my K award. We're doing kind of a wholesale theory-based assessment of the treatment of patients with bladder cancer at Memorial, and looking at determinants of referral and utilization of our tobacco treatment program. And this is kind of where a lot of the work in my my K award will hopefully come into play. And as I mentioned, my K proposal, which is unfortunately in budgetary hold at this point, was a mixed methods sequential explanatory study. Aim 1 was a quantitative assessment of the iterative loss along this process. The second aim was a qualitative assessment of determinants of these practices in both clinicians and patients. And then the third aim was a pilot of a adapted implementation strategy and a pilot study from there. And the long-term goal of this is to disseminate this adapted strategy in surgical oncology clinics within the Cancer Center Cessation Initiative centers. So just to kind of close the loop here and bring it all back to the ultimate goal, and that's improving the tobacco treatment in our patients. I think if anyone listening to the call does want to take the next step and kind of start to look at this locally, I think the most important thing is to first understand your current practices and resources and the context of where you're delivering care, whether these patients would benefit most from having this done prior to your clinic visit, after your clinic visit, within the clinic, potentially through the tobacco treatment program, if the center is fortunate enough to have these resources. It is important to remember that Northwestern and Lurie Cancer Center both, or rather have a tobacco treatment program. So I think it would be interesting to kind of hear when we finish up what people's experiences have been using that and what the referral process is. A lot of these are automated referrals. Some are need more directed referrals, including smoking cessation pharmacotherapy in post-op order sets. Again, this is something that we're starting at Memorial to have this automatically included in anyone who is an active smoker in the EMR during their either cystectomy or TURBT visit. And then really when you start doing this, is to use validated instruments and try to build structured data just to really leverage the health IT aspect and the benefit, one of the few benefits of having the electronic medical record. It's important to think about this ahead of time. And then finally, when you ultimately get down to trying to choose a strategy and trying to improve this, it's important to really get stakeholders at multiple levels and understand that you can, try to get patients or providers to do a certain thing, but really some of the biggest barriers are at the system level, and those need to be addressed in certain specific ways. So to close it out, just to reiterate what evidence-based smoking cessation treatment should look like and what we should probably be doing more of as urologists. And really step one, again, is screening for tobacco use and hopefully using a validated instrument. The second is really getting patients these evidence-based treatments. That's a combination of counseling and behavioral therapy and pharmacotherapies, and really continually assessing patients as we continue to see them in our clinics, specifically for bladder cancer, because of how much follow-up is required. These are really continued opportunities to assess and intervene. And this is a plug for a patient page that we put together in the last couple of years. This is something that can be given to patients. I do have a stack of these that I hand out that kind of helps explain some of the justification for all of this. And this particular document also does have some free resources like the 1-800-QUIT-NOW and smokefree.gov resources that we can direct people to. And then lastly, future directions for this work. I think that I didn't spend too much time on it, but some of the e-tobacco products are certainly an important aspect of tobacco use, given the concern that although this may be risk reduction, how much risk are we reducing, and how much persistent risk is there still in these tobacco products? Doing translational correlative studies, specifically looking at some of the findings we've determined, such as the intravesical chemo paradox, and that intravesical chemo may actually be more effective in current smokers who have high-risk disease, potentially because of the cumulative DNA damage induced by both of these things. Looking at a combination of genomic drivers of both bladder cancer outcomes and quitting. This is something that Dr. Furberg, one of my collaborators here, has really published extensively, looking at genetic determinants of smoking cessation and addictive behaviors. And then really using and leveraging our EMR and all the technology around us to kind of develop this learning health system approach to delivering evidence-based care in surgical oncology. And smoking cessation is certainly only a small part of that, but that's really ultimately the goal in taking care of patients, is actually letting some of our technology work for us. So I'll finish up there. I think a little bit ahead of time, fortunately, but I absolutely wanted to thank Dr. Schaefer and Dr. Ross for the invite and allowing me to speak. Certainly, Dr. Kield, the rest of the faculty at Northwestern, my co-residents, for supporting all the training, and I'd be remiss not to thank Dr. Makarov and Sherman at NYU, who were two of my mentors before I came over to MSK, and certainly continue to be close collaborators and mentors. Mark Bierlin at UNC, who's been an amazing collaborator and someone who I've done really some nice parallel work with, and then everyone at Memorial, Drs. Ostroff, Furberg, and Dr. Bachner, who continue to mentor and support me here with all this work. So thank you very much.
That was great, Rich. Any questions for? How do you, so do you find, is MSKCC, how are they related to different sort of internal medicine practices and private and community practices? And how do you interface with I may have missed it if you talked about it, but how do you interface with their primary care doctors?
Yeah, so there is a bit of a disconnect, certainly more here than at a more integrated system like Memorial's, like Northwestern. It's a challenge, and I think it's part of the reason also why we end up doing a lot of what we do in-house, because there are that EMR connection that we're in the same building or down the hall or something is not necessarily there like it is in other kind of complete tertiary care centers. So it's tough, but that is why the tobacco treatment program and everything that is put in place here, it makes an attempt to be more of a freestanding approach.
Hey, Rich.
Hi.
This is Courtney. Hey, enjoyed your talk. As you know, I've been kind of beating this drum about smoking cessation, the role of smoking in bladder cancer for about 25 years now.
Yep.
And I remember the first time I gave a talk on this very topic. Let's just say not many people were leaning in. And I think, but after over the years, it started to sink in. And I think that you and Mark have realized that there's something here, that in fact, we have to think about the fact that cigarette smoking is still the leading cause of premature and preventable death in the United States today. And that the important part about that is that you got to think about, if that's true, that particularly in patients with non-muscle invasive bladder cancer, getting them to quit smoking might be the number one public health impact that we as urologists can have on that patient. Now, I know that's hard to digest because we're thinking about the bladder cancer itself, but in non-muscle invasive, particularly low-grade bladder cancer, you might be making a greater public health impact on your patients by not doing the bladder cancer, but getting the patient to quit smoking. Now that's, I know some people might say, wow, that's a big statement, but it's a true statement. And so if you look at the public health impact, and the other is that we have to understand, which you did a really great job of kind of laying out, is not only the patient needs to be motivated to quit smoking, but the role that the urologist can play in that. There have been very good projects being done, one of which I wrote a editorial comment with your article that was in the Gold Journal. And I think you guys hit the nail right on the head, in that we have to really understand that there is a point at which we have to seize the moment. It's a finite moment in time that this patient is open for a teachable moment. And it requires that urologist not only being motivated to do this, but also to be knowledgeable in doing this, right? And that paper that you alluded to, that years ago, that when we looked at American urologists, the first thing that jumped out to me was that urologists have a very low rate of even discussing smoking cessation with our patients. But what's interesting is that if they had formal education in smoking cessation assistance, they were far more likely to implement smoking cessation assistance. I mean, that's not earth-shattering information, but what we're doing in educating, the urologist or even the oncologist on how to successfully implement it, you're going to increase the rate of smoking cessation assistance with that alone. So my hat goes off to you, and great talk.
Thanks so much. Yeah, obviously I agree with everything you said. And, I've been pushing the AUA for almost 2 years now to try to put out a white paper or something that provides some educational tools for urologists, because I do agree, we're very hyper-focused on a lot of the technical aspects of what we do every day, but we may be missing some of the bigger ticket items, like smoking cessation and like some of the other lifestyle things that we can actually be very strong drivers of, even more so than primary care doctors, simply because of the relationship we have with patients. So,
hey, Rich, on that point, is there a expert opinion guideline statement in either the non-muscle invasive or muscle invasive bladder cancer guidelines that basically says smoking cessation should be discussed?
There is in some. One of the recent publications, Mark and I just had with one of the students at UNC, looked at that, comparing it to the lung cancer guidelines, and it's only mentioned in about 40% of all of the bladder cancer guidelines in all of urology. So this includes the European, the Canadian, the American, all of these types of things. So, I mean, frankly, it should be 100%, right? Like, I think I really belabored the point that this is still impactful even after diagnosis. And, as Dr. Hollowell said, certainly can be even more impactful in people who don't have deadly disease. So, I do think it should be in every single statement, but it's not. I think that smoking cessation is mentioned in, if I'm remembering, in the European guidelines, maybe explicitly, but not in the AUA guidelines. But one of them has screening. I actually don't remember off the top of my head, but it's pretty deficient. Yeah, the AUA does not have tobacco screening, but it does include smoking cessation.
Another, Rich, area that, has jumped out at us, and I know that you guys have taken on this subject as well when it comes to smoking, because there's so many different angles, particularly with smoking cessation, is we looked at the predictive risk factors for a patient who comes to you who is a smoker, who's got a genitourinary malignancy, and what are the predictive risk factors for continued smoking? The reason why that's so important, and I like that you guys even looked at this as well, we had a paper on this as well. We looked at it from a different angle, where we tried to examine things that the patient may have by giving sort of inventories to that patient, like anxiety and depression inventories, looking at whether or not there's a smoker in the home. All of these things may increase their risk of continued smoking. The reason why that's important to us as the urologist is that maybe this may be beyond our scope, and that we have to know that, look, this is someone that I need to get even more comprehensive smoking cessation assistance to. And so if you can identify, who these patients are up front, we can get these patients even more intensive, treatment as well.
Yeah.
Are you guys using, I'm curious, you guys obviously are using nicotine replacement therapy, but are you using varenicline at all? Chantix?
Well, yeah, that became a little bit of an issue recently because of the contamination of the drug. So that was put on hold for a bit, but it had been part of the algorithm.
Yeah, I've been pleasantly surprised before all that at how well many patients respond with even Chantix. So it's definitely another thing that needs to be in our armamentarium. And I find that if you're not familiar with any of these drugs and using them, like you've said in this discussion, you're far less likely to use them appropriately. Another one that jumps out is the use of combination therapy. We've all kind of been potentially taught to treat these individuals with one, like nicotine replacement therapy, when in fact you can use multiple drugs, multiple ways of giving nicotine replacement therapy at the same time. Not very different from having someone who has, if you have breakthrough pain, you may take a lozenge, for example, but you may be taking a slow-acting drug to help you with your pain as well, like a patch for nicotine replacement therapy. And most of us don't know that because we haven't been taught how to, give nicotine replacement therapy.
Yeah, absolutely. I mean, that's very evidence-based, that both a long-acting and a short-acting NRT, even in addition to the prescription drugs. And I think just like other disease processes, being very aggressive upfront has been shown to help.
Yeah. Did you touch on today about the prospective sort of evaluation of your recurrence of bladder cancer in patients who are continued smoking versus those who quit? Did you touch on that project?
Yeah, a little bit. And I think at this point, years ago, the data were very much in favor of continued smoking causing recurrences, or at least being associated with recurrences. And now I think some of the more recent studies, it's a little bit more equivocal. The bigger issue is just the quality of the data also, in that just simply assigning someone a designation of never former recurrent smoking is probably woefully inadequate. I think that the duration of smoking is certainly influential. The intensity of smoking is influential. And, the crux of the problem in both the clinical and the research setting in this, especially in urology, is just the lack of quality data. Someone who's a former smoker that smoked 5, pack years 20 years ago is not the equivalent of someone who, smoked 40 pack years and quit last week. But unfortunately, in many studies, that person will be labeled the exact same way. So I think that a lot more work needs to be done in that. Dr. Furberg here really has a nice, elegant study with a lot of urinary biomarkers, saliva biomarkers, and we're really looking forward to diving into some of the correlative science of this, especially with some of the MSK impact availability we have with a lot of these patients, the next generation sequencing and stuff.
Well, once again, that was fantastic, Rich. I really appreciate you being here and being with Northwestern. As you noted, we have a large, primary care component to our system. Dr. Hollowell obviously has a large system and huge amount of interest, as he stated. As you look at different methods for implementation and different places that you want to enact, trials, I'm positive I speak for the rest of our faculty here, and that we'd love to partner with you. So anytime you want to reach out. But thanks everyone for their attention. and stay safe and have a great evening.
Thank you. Take care, everybody.